Yes,
You can see me?
Yes, we can see you. Uh,
You can see? Share?
yeah,
Okay, it's okay.
it's great. So, hmm, let's start, yes? Ida, can we start?
yes, please. We are already recording. We are ready to go.
Okay. Good morning, good afternoon, and good evening to everyone joining us from around the world. Dear colleagues, welcome to day 2 of the WATOG Joint International Webinar. On behalf of World Association for Trainees in Obstetrics and Gynecology, it is my great pleasure and honor to welcome you back to our international scientific webinar, Building Bridges in Maternal Fetal Medicine, as begin session 3 and 4. My name is Hasmik Beragamian. I am an obstetrician and gynecologist at Beglarian Medical Center in Armenia and a lecturer at Yerevan State Medical University. I completed my PhD in adolescent health and reproductive medicine and currently serve as the honorary treasurer and former Asia representative of WATOG. I am an associate editor of International Journal of Gynecology and Obstetrics, and I am a member of International Federation of Fertility Society Next Generation Team. It is a privilege to welcome you to today's program organized by WATOG in collaboration with FIGO, the International Federation of Gynecology and Obstetrics, the European Network of Trainees in Obstetrics and Gynecology, the European Board and College of Obstetrics and Gynecology, the Kenya Obstetrical and Gynecological Society, and the African Regional Branch of the WATOG. Before we begin, I would like to thank all of you for the outstanding engagement yesterday. We received an impressive number of thoughtful questions reflecting the tremendous global interest in maternal fetal medicine. Day 1 highlighted several important aspects for contemporary maternal fetal medicine. We are explored the human side of care, emphasizing respectful maternity care, early maternity newborn bonding, breastfeeding support, and the prevention of adverse childbirth experience. We also discussed prevention and screening, from optimizing maternal health before pregnancy to the early identification of pregnancy risks and the challenges of accurately assessment fetal growth across diverse populations. The discussions reminded us that improving maternal and fetal outcomes requires not only scientific knowledge and advanced technologies, but also comprehension, collaboration, and patient-centered care. Today, we build on that strong foundation as we move into session 3 and session 4, focusing on diagnosis and fetal impact, following by genetic, research, and global perspectives. These sessions will continue our exploration of the latest advances in maternal fetal medicine through evidence-based presentation and international collaboration. It is my pleasure to introduce today's co-chairs, Dr. Safia Tiapakidu, President of ENTOG, and Dr. Leopoldo Santiago, Honorary Treasurer of WATOG. Welcome, dear co-chairs. Today, we will enjoy 6 expert presentations with 3 lecturers in each session. Before we begin, I would like to briefly explain today's format. Each presentation will be followed a Q&A session. Please feel free to share your comments in the chat. We will answer as many questions as time allows during the live discussion, and any remaining questions will be answered by the speakers in the Q&A session after their presentation. Finally, please note that certificates of attendance will be issued after you complete the post-webinar survey. Your feedback on the quality of the webinar, its educational value, and your interest in future global maternal fetal medicine webinar is greatly appreciated and will help us plan future events and improve the quality of the webinars. Now we are delighted to begin the second day of our scientific program with our first speaker, Sezin Karsli, an obstetrician and gynecologist from Turkey, with a strong commitment to reproductive medicine, medical education, and international collaboration. Dr. Karsli completed her scientific training at Ankara Bilkent City Hospital and is currently undertaking advanced IVF training at Hacettepe University. She served as a vice president of the Turkey Trainees of Obstetrics and Gynecology and European regional representative of the International Federation of Fertility Society Next Generation team, actively contributing to education, network, the professional development among young specialists worldwide. Today, Dr. Karsli will present an important topic, preeclampsia the prevention strategies. We are honored to have Dr. Karsli with us today and look forward to her valuable insight. Dr. Karsli, the floor is yours.
Thank you, Hasmik, for your kind introduction, and thank you also for inviting me to this amazing webinar. It's an honor for me to be here. So today, I will, can you see the slides? I hope you do. Okay, you can see. Okay, so today I will talk about preeclampsia prevention strategies, and I have nothing to disclose. Yesterday also preeclampsia was mentioned, but let's remind, preeclampsia is a syndrome with the new onset hypertension plus proteinuria and organ dysfunction, or both after 20 weeks. In individuals with pre-existing hypertension, worsening of hypertension plus proteinuria and organ dysfunction, or both after 20 weeks, suggests preeclampsia. Why preeclampsia is so important? Because let's remind ourselves that 70,000 maternal deaths attributed to preeclampsia each year, and this is a very much number. What was the risk of developing preeclampsia? If we look to a high-risk group, we see, as you remember, the chronic hypertension, chronic kidney disease, multifetal pregnancy with a body mass index of higher than 30, assisted reproductive technology usage in the development. These are the risk factors for developing preeclampsia. So what can we do to prevent? Low-dose aspirin is one of the most important aspects of this. Who should receive it? With the risk individuals with the high risk factors, aspirin should be given. And dose and timing, their standard dose is 80 milligram per day, or some evidence supports 100 to 150 milligram per day. We will discuss this later with the guidelines, of course. Start is 11 to 14 weeks of gestation, ideally before 16 weeks. Continue until birth. Some protocols stops at 36 weeks. Additional for preeclampsia prevention, we could also Definitely chronic hypertension control. Treating mild chronic hypertension lowers the risk of preeclampsia. And also preconception weight and gestational weight gains is important because the body mass index being higher than 30 is a high risk factor. So we should control this one if we can. And about heparin, current evidence does not support adding heparin. And there will be additional prevention strategies, but these will be discussed by Zahra later this webinar. So also in screening process, Nikolaidis and Professor Nikolaidis et al. Have a paper, maybe you can remember, with ophthalmic artery Doppler, and they suggest that at mid-gestation, this is superior to all other established individual biomarkers in predicting both preterm and term preeclampsia. And the aspirin trial is a very important one in this aspirin aspect. This was a randomized, double-blind, multicentric trial, and they gave aspirin 150 milligram nightly from 11 to 14 weeks until 36 weeks of gestation. And the outcome was 62% reduction in preterm preeclampsia, which is very impressive. So what the major guidelines say, FIGO says that also 150 milligram nightly, and NICE guidelines say 75 to 100 milligram daily, and ECOG also say 80 milligram daily. And now I would like to present a case report from our hospital to further demonstrate the preeclampsia. Let me take you to Şanlıurfa in Turkey. This hospital was near the Syrian border, and we had 24,000 deliveries in a year. So it's a very high center. And we have Göbekli Tepe here. If you visit there, it was founded in 10,000 years before Christ, so it is even older than Stonehenge. So let's go to our case. It was a 90-year-old patient, nulliparous patient. It was her first pregnancy. She was presented to ER with severe headache, epigastric pain, blurred vision. Headache was unresponsive to analgesics. Her blood pressure was 160 to 170, and even after nifedipine, it was 180 to 120. With a heart rate of 160, she had a history of methamphetamine use before and during the pregnancy. Ultrasound findings showed the fetal biometry was consistent with 32 weeks. It was normal FA, cephalic presentation, but placenta with the aproptio suspension. She had also diffuse free intra-abdominal fluid and bilateral vulvar edema. This patient had no prenatal care, let me remind again. And so because of the suspected abruption and setting in the severe preeclampsia, we performed emergency cesarean section. And here you can see, this is after the skin incision. Only the subcutaneous tissue had this much of fluid. We are not in the abdomen yet. And in the abdomen, I would like to show you, we had still too much assets. We had 4 liters of assets removed in this case. Blood work in the emergency admission, the creatinine was 1.02. And other than that, we didn't have any pathological laboratory findings. So we put the patient admitted to the obstetric ICU, and we after 24 hours we referred to the university. But during this 24 hours, she was alert, oriented, no active vaginal bleeding. Postpartum uterus was normal on the ultrasound. We gave magnesium loading and maintenance. We gave albumin twice, cefazolin twice, and we gave nifedipine 30 milligrams twice daily. We did cardiology consultant, and they didn't have any further recommendation. Prior to transfer, the drain out was about 2 liters per hour, so it was a little too much, and a fluid balance ordered to target in the first 24 hours of the operation to stay in plus. And after in the university, a multidisciplinary consultation were made. She was consulted ophthalmology, neurology, cardiology, pulmonary disease, and risk was discussed with the patient and their family. And after cesarean section, the highest blood pressure was 140. We didn't have any problem with that. And these are in the university, of course. Post-operative day 2, the drain output with this medication follow down to 300 milliliters, and after that, in post-operative day 4, we could even remove the drain. If you remember, in the first 24 hours, the fluid was coming too much, 2 liters per hour. But after the medication and the cesarean section in the university, they didn't have such drain output problem. And addition consultations made to the multidisciplinary action. And she could be discharged on postoperative day 6, hemodynamically stable, no complications occurred. Cardiology outpatient follow-up was arranged. And what we learned from this case is without a prenatal antenatal follow-ups, the pregnancy carry compounded risk. Substance use in pregnancy can mask or mimic hypertensive presentations, and they can complicate the disease. Persistent hypertension postpartum variance escalation and multidisciplinary workup can be needed. And close monitoring of drain output, vitals, and uterine tone allowed safe care. So thank you for listening me. This is my team from the Şanlıurfa with this high number of labors, and this was a case from there. Thank you for listening me.
Thank you so much for excellent presentation. Case presentation was awesome. For your excellent and clinical valuable, also thank you, dear Dr. Karsley. You have highlighted the importance of moving from risk recognition and effective prevention in preeclampsia care. Your discussion on risk stratification, aspirin prophylaxis, and practical implementation strategies provided important insights into how evidence-based interventions can improve maternal and perinatal outcomes. Thank you for sharing your expertise and for contributing to these important discussions. So we will now open the floor for questions. Please submit your questions in the chat and we will address them during the discussion. But before this, I have 2 questions for you. Why is aspirin recommended to be taken at night? And second one, should we give aspirin to all pregnant women?
Thank you for the questions and thank you for your kind words again, Hasne. As for aspirin, there was a study with AI et al. And they look at aspirin during morning, afternoon, and night. And they found out that if you give the aspirin during the night before bed, it has better outcomes with preeclampsia. Also, with the aspirins, upper GI effects like nausea are reduced when the patient just take it and then go to sleep, and then she feels less nausea. And the other question was, yes, aspirin is a wonderful drug, but still it has some side effects. It is not a safe drug, so we can't just give it to everyone. It can cause to bleeding because there was also patient with cardiovascular risks. Even non-pregnant patients received aspirin and they see some side effects like intracranial hemorrhage or GI hemorrhage, bleeding. So it is not a fully safe drug. So we should give them to high-risk patients, not all of the pregnant patients, because it's also not ethically correct, I believe, to just give the aspirin to everyone. Thank you.
Thank you so much, Dr. Karslin.
Now let's continue for the day 2 and the next speaker. We are delighted to welcome also our next speaker, Dr. Rami Novoa, an obstetrician and gynecology from Peru, a pre-doctoral researcher in Fetal Medicine Research Center in Barcelona, Spain. Dr. Novoa holds a Master of Science in Epidemiology Research and also extensive experience in epidemiology, maternal fetal medicine, and contributions in fetal therapy, prenatal care, preeclampsia, and prenatal outcomes. She has a lot of publication, presentation, and leading international congresses, including FICO and the World Congress in Fetal Medicine. Today, Dr. Nova is going to present us an important topic, cardiovascular programming in fetal growth restriction after day 1, and Dr. Jenny Miranda about fetal growth restriction. Now we're going to have a deeper dive into this subject. Thank you a lot for being among us, Dr. Nova, and the floor is yours. We can see your presentation.
Okay, thank you for the kind invitation. It's an honor to be here sharing this important topic in fetal growth restriction. And well, it is probably a no common topic, and it is so important to know about it. I have nothing to disclose. And what is the origin of this topic? Because in Barker was an epidemiology from UK that he discovered or maybe took attention in these maps that there are from the beginning of the last century and 70 years later. And the findings was the interpreting as evident that the second one, the right one, it was the mortality, the infant mortality during those years, and the similarity of the death rates from coronary heart disease 70 or 80 years later. The maps were similar. These findings have been interpreted as evidence that adverse living conditions during childhood probably, for example, poor housing or diet, increase the risk of ischemic heart disease a lot of years later. And this is the origin of this hypothesis. And well, cardiovascular programming this is one of the articles of Barker, the fetal and infant origins of adult disease. He thought that the womb may be more important than the home. And the origin is the coronary heart disease originates through responses to undernutrition during fetal life, which permanently change the body's structure, physiology, and metabolism of the fetus. And this is the graphic where as lower is the birth weight, higher is the death, the rates of death from coronary heart disease. And well, what is the exactly mechanism of this association between mortality from cardiovascular disease and low birth weight that Barker described more or less 4 years ago? Well, the low birth weight is not simple. A newborn with a fetal growth restriction condition during intrauterine life develops spherical, as you can see here, the difference of these two hearts, hypertrophic and less efficient hearts. All these changes are caused by placental insufficiency. Well, after birth, this cardiac remodeling persists this is the words of my team research here in Barcelona. They reported that during the childhood and pre-adolescence, the changes persist with more globular heart, reduced motion, and impaired relaxation of the hearts during even in pre-adolescence. During last year, we published this paper with the during not only pre-adolescence, during the adolescence and the adulthood. SGA seemed to be improve that changes, but they demonstrated a reduced exercise tolerance. And it is other study during the adulthood, they demonstrated the same. But what is the relation with the cardiovascular disease? What is the disassociation between the beginning of the changes during intrauterine life to the heart attack, for example? Well, fetal cardiovascular programming, based in placental insufficiency, the hypothesis is that they cause epigenetic changes. It's not a genetic change, it's an epigenetic change, probably because sustained restriction of nutrients and oxygen is associated with cardiovascular remodeling at organ, tissue, and subcellular levels. And this is the case. It's one of our pair stars in our study. Twins. They are twins, dichorionic, diamniotic. They were born at 30.4 weeks. The name's Maria. Maria was had a percentile, a normal percentile with umbilical Doppler and the heart totally normal. And her sister Carlota had a percentile 1 with this Doppler of the reverse umbilical artery and this heart. As you can see, this is a very different heart, different from her sister. Very globular heart, hypertrophic, and less with less power to eject blood. Well, these twins were born at 30 weeks, and they has been followed for almost 22 years. Last year, we evaluated them as a group of as a cohort that here in Barcelona we are following. And Maria and Carlota, during the fetal life, sorry, they had as growth retardation increases in Carlota, the dysfunction of the heart increased. For example, isovolumetric relaxation time, decreased tissue Doppler, and a BMP, a very, very potent marker of dysfunction of the heart, increase in this type of fetuses. During the childhood, as in the postnatal phase, we saw that Carlota was still experiencing, as you can see here, these changes with a more globular heart, decreased longitudinal motility, a stroke volume. This study was done at 5 years at age, and someone make ask, wait, while Carlota was in the womb, it's normal for her heart to have undergone changes to adapt to lack of oxygen and nutrients. But at once she was born, she was being fed normally as her sister. The mother feeds equally, both of them. But why why is not the case that Carlota normalized the heart? Because Carlota's heart has already been programmed, already designed to adapt to that environment that is like to one of she thought was normal. Undernutrition and hypoxic environment, so that the heart has developed to adapt to that environment, and so it has remained and so it will remain programmed, and this permanently throughout the life. In postnatal vascular evaluation of the twins, we found that vascular remodeling in the IMT, in the carotid images, and we showed here the pre-hypertension and pre-atherosclerosis in Carlota, different from Maria that she was normal intrauterine. In animals, in models, for example, here in rabbits, the literature demonstrated the predominance of circumferential fibers and dilated coronary arteries. That means that there are more changes than we thought. And intracellular structure is changed too. In pre-adolescence, our group followed up these patients, and they found that a persistence of cardiac remodeling, as you can see here, both hearts of Maria, Control, and Carlota, IUGR, even in pre-adolescence, with longitudinal motion and impaired relaxation. And we published this paper that we demonstrated that these hearts change from pre-adolescent to adolescence, and fetal growth restriction hearts remain some proportion of the changes during fetal life, but they demonstrated that probably a catch up with the controls. However, when we evaluated the blood pressure in a basal state, they were similar. They so normal, but during stress, they had an exaggerated systolic blood pressure values. That means that IUGR adolescents persist with a vascular change programming because the undernutrition during fetal life. And even they demonstrated a less tolerance to exercise in adolescence period in adulthood. Well, and this is the last photo, the previous year in 2025. We follow up Carlota and Maria, and now they are 22 years old, and the difference continue. We are ongoing, it is an ongoing research work. And well, what is with this data, that all of this data, it's obviously that the fetal programming is in our patients even when they was born. During fetus life, the epigenetic changes produce this adaptation to undernutrition, to hypoxic conditions that persist during all life. However, we consider this change during fetal life as a first hit. What that means, that it is this adaptation, this population are in high risk to probably during all their lives to have a heart attack or every cardiovascular disease. But when we have another, even this susceptibility, we have another hit. This is we named the second hit, and this second hit could be related to the lifestyle and factors as tobacco, physical activity, stress, diet, and others condition. And this is the second hit that probably induce a heart attack or hypertension or other final disease. And this is an opportunity, probably this knowledge, with this knowledge, we have the opportunity to correct that nexus. And what is the evidence? The evidence suggests that early life interventions can have a strong effect on the cardiovascular changes that are associated with fetal growth restriction. what type of corrections, for example, of breastfeeding, has demonstrated that it's a very, very good intervention to reduce this programming. What other factors? Factors related with prenatal environment have demonstrated a relationship with the origin of fetal growth restriction and therefore with cardiovascular programming. This factor, infection, stress, suboptimal nutrition, tobacco, and malformation, for example. And this is opportunity. The clinical trial, the impact clinical trial demonstrated that with a Mediterranean diet, we can reduce the fetal growth restriction and the fetal cardiovascular programming, not only Mediterranean diet. This group studied only the stress reduction with mindfulness. And it's important to us as a gynecologist and as obstetricians to know how can we evaluate these hearts. We need to know the cardiac morphometry to measure all of the fetal hearts to demonstrate that probably in a fetal growth restriction fetus, if that fetus has or not a different morphometry and function. There are a lot of papers, for example, to demonstrate cardiomegaly, ventricular dilation, globular shape of the heart, and myocardial hypertrophy, and all of the alterations that probably this heart is suffering a fetal programming. It's important as a gynecologist to know this type of measurements. Okay, and our conclusions is that the fetal growth restriction induces cardiovascular programming and remodeling, and that is plausible that these changes pose an increased risk of cardiovascular disease later in life. This subclinical remodeling in growth-restricted fetuses entails a higher predisposition, but these changes need to combine with other factors, the second hit. And this is a window of opportunity, and this opportunity must be as early as possible. We need to identify these fetuses at risk of adversarial fetal programming in order to provide an optimal prenatal care and implement early life interventions as a Mediterranean diet, stress reduction, and good lifestyle aimed to reducing future cardiovascular disease. Thank you very much.
Thank you, Romy. It's a fantastic speech, fantastic presentation. I love it very much.
Thank you.
This presentation was really excellent and thought-provoking. And thank you for sharing your expertise and for expanding our understanding of how the intrauterine environment can influence long-term health outcomes. Thank you so much.
And thank you, Dr. Novoa, for this presentation. Actually, I have a clinical question. Now,
Okay.
in our FGR, in our SGAs, what counseling can we do in long term, let's say? Not only for the lifestyle modification of the long-term risk, but how can we, if someone reads something about it, or the AI gives some information for their own, how we can make them clinically informed at the same time, not to worry about their lifetime span, let's say.
Yeah, of course, I understand. Well, when we have a IOGR fetus, it's important in the first trimester, for example, we know probably the risk of the patients, and even there are not a lot of intervention that we can do, but the two probably the diet, the stress reduction, the good lifestyle during the pregnancy, it's important for this high-risk pregnancy of preeclampsia and IUGR fetuses. There are other, probably the aspirin is not um, intervention that for all our patients, but it's important to say the patient, the counseling must be focused and interventions to reduce the risk of fetal growth restriction. Only we have not medically, no, it's only diet, stress reduction. And the second and third trimester, when we identify that fetuses, probably the follow-up in all our guidelines to the termination of pregnancy during the most severe IUGR. However, it's important to say the family, to the mother, that these fetuses are in high risk too, obviously, in the later in life to this fetal cardiovascular programming. And the breastfeeding, for example, it must be mandatory for these patients, and other activities to reduce the long-term programming and bad outcomes. For example, the good lifestyle for that children. It's important.
And thank you very much. And to take a little bit further that question, can we suggest, not as gynecologists, but like physicians in general, to have exercise for these kids? Because for the first 5 years, let's say we have a close relationship with these families. So does help, or it's something that maybe provokes any further remodeling, maybe, in this already small heart?
No, but the remodeling is adapting during the very the first years. We demonstrated that the hearts continue with this, for example, globular form, but it's important to good lifestyle for that children, not obesity, for example, exercise. Yes, not it's not a contraindication for that babies, for that children.
Thank you a lot. Thank you.
And one more question, please. In low and middle income countries where long-term follow-up may be challenging, what practical strategies would you recommend it to improve surveillance and cardiovascular prevention for children born after fetal growth restriction? Because now we have a lot of children with this kind of disorder. So as a clinician, I want to listen your talk about this.
Well, it's very difficult in a low income settings. I'm from Peru. I understand what is the conditions there, for example, but it's important as part of the health program to include a counseling about this fetal cardiovascular programming in the mothers in the postpartum period. It's important uh, to have, for example, a, a people that know about that, because when the mother left the hospital, probably they don't know nothing about the condition of the heart of that babies. They think that probably all is normal because they are left the hospital, but it's important to say no. You need to maintain that baby in these ranks of weight, good diet, good exercise, Mediterranean diet, for example. But in low setting income, it's important that information must be part of the program hospital, a very specific consult, as for example, preeclampsia, postpartum preeclampsia consult must be there in the hospital.
Yeah, thank you so much.
Well, moving on, we are delighted to welcome our next speaker, Dr. Sarah Muslim. She's an obstetrician and gynecologist from Pakistan, Bachelor of Medicine, Bachelor of Surgery with a special interest in reproductive medicine, fertility, and evidence-based women's healthcare. Dr. Muslim is a fellow of the College of Physicians and Surgeons in Pakistan. She serves as a communication manager and Asia ambassador for the International Federation of Fertility Societies, and she also holds leadership positions within the Pakistan Menopause Society and the South Asian Federation of Menopause Societies. Through her clinical work, research, education, and international collaborations, she continues to contribute to advancing women's health worldwide. Today, Dr. Muslim will present an important topic: beyond aspirin, the role of L-arginine, calcium, and target supplements in preeclampsia prevention. We are honored to have Dr. Muslim with us today and look forward to her valuable insights. Dr. Muslim, the floor is yours.
Thank you so much, Leo, for the overwhelming introduction. Thank you. Without further ado, I will begin my third talk for today's webinar, Beyond the Aspirin, the role of L-arginine, calcium, and targeted supplements in the prevention for preeclampsia. So I have nothing to disclose. I will begin my talk with a case of 29 years old from South Asia at 10 weeks of the gestation with a family history of sister having eclampsia. On today's visit, having a BP of 128 by 84 mm of mercury with the booking bloods normal, no placental growth PIGF assay available at her district hospital. So, knowing the family history, the question is, is there any possibility to prevent preeclampsia? So there are usually three questions if we are well aware of the prevention. So is aspirin alone is sufficient, or do we need more about it? What does the evidence says about the other supplemental therapies, including the L-arginine and the calcium? And what are the practical, evidence-based practical tools for the women that we can offer today? If we look into the burdens of these pregnancies, it is about up to 8% worldwide. There are 76,000 preventable maternal deaths, according to the survey conducted in 2024. And in 2023, by WHO, 500,000 perinatal deaths per year was reported because of hypertensive disorders in pregnancy. In my country, the incidence is a bit higher, is up to 12%. It is one of the leading cause of the maternal mortality, published an article in 2022. And one of the survey conducted by the WHO is that the dietary intake of the calcium is less than 200 grams per day for the women living in South Asia. And fetal-maternal is the first trimester screening is available hardly in less than 10% of the facilities. And the subscription of the aspirin at the time gestational age is up less than 30%. And antenatal care guidelines recommend the calcium intake of 1.5 gram per day. However, the compliance is noted to be poor. The clinical consequences, we are very all aware of it, are the maternal, including the eclampsia, HELP, then going to the fetal are the FGR being most common. The long-term being noted is 2 to 3 times lifetime risk of the cardiovascular risk in the mothers with the metabolic syndromes in offsprings. However, the low and middle income countries, the burden share 44% of the global preeclampsia death in South Asia and Sub-Saharan Africa. Why it is said that one drug is not enough, usually? There we have a two-stage pathways. If we take the first trimester, there is a defective trophoblastic invasion, shallow spiral artery remodeling with the placental hypoperfusion. This is where the aspirin actually acts at the first trimester by improving the trophoblastic invasion and restoring the TXAs and prostacyclin balance that we are required important in the first trimester. The second pathway, stage 2, is the second and a third trimester. The ischemic placenta releases the SFT1 and PIGF levels drops. So systemic endothelial functions follows. This is a clinical preeclampsia we usually see. And looking into the three interventions, the aspirin targets the TXA2 and platelet aggregations, and L-arginine, if prescribed up to 3 to 6 gram per day dose, restores the nitric oxide, a completely different mechanism. However, the calcium, if given, is targets the parathyroid and renin vascular endothelial system. There are some trials already published with the low-dose aspirin. The aspirin trial of 2017 shows the decrease of preterm birth to 62%, whereas other trial followed in 2017 again shows that the 76% of the early onset of the preeclampsia could be presented, and a higher dose and early start has a superior benefit. If the 2021 Lenson study showed the low-dose aspirin conducted in LMICs shows an 11% decrease of adverse outcome and decreased preterm preeclampsia. The gestation age of prescribing the aspirin is very important. The prevention is more than 80% if it is begins by before the 11 weeks and 76% if it is between 11 to 14 weeks. However, the advantage is quite less if prescribed after 60 and 20 weeks. L-arginine, what is it? It is a semi-essential amino acid, conditionally essential in a pregnancy, can be obtained in the form of a diet, fish, nuts, meats, soy. Endogenous synthesis from the L-citrulline. It is a primary substrate for the endothelial nitric oxide synthetase. It acts on 5 pathway systems for the vasodilation, antithrombotic activity, anti-inflammatory, pro-angiogenic, and antioxidant required for the good flow in the placenta. So, what is the L-arginine pathway to it? Is the substrate with nitric oxide synthetase enzyme releasing the NO and downstreaming the effect. However, ADMA, which is significantly elevated in a preeclampsia, it completely inhibits the synthase enzyme, so ultimately decrease in the nitric oxide and increase of the oxidative stress cascade, which we see in the cases of preeclampsia. So, L-arginine alone, there are key published trial by in 2006 by the Retwelsky, shows that increased level of the NO was noted, which prolonged the pregnancy on average of 3 weeks and however resulted in reduced NICU admissions. Followed by another trial published in 2016 shows the decrease in the mean arterial pressure and decrease of proteinuria at a 4 weeks follow-up. One of the study published by Pakistan in 2022 highlighted that the L-arginine reduces the preeclampsia incidence in Pakistan. The result also shows that there was a better in the amniotic fluid volume, better Doppler outcome. Other studies was conducted in Iran, again shows the severe reduction of preeclampsia as compared to the control group of 19%. Some of the meta-analysis of L-arginine and aspirin shows that in 2011, which is a landmark randomized control trial, shows that 47% reduction in the preeclampsia, reduced preterm birth, reduced hospital admissions. Additive benefit beyond the aspirin alone was noted because the aspirin and L-arginine were completely in different pathways but complementary to each other. Followed by another study of 2014, 10 randomized control trial by Gui-Mehta, relative risk of 0.57 for the preeclampsia, significant reduction in both the systolic and a diastolic blood pressure for the mother, consistent signaling across the different population. One of the study, which is the most recent in 2025, shows the most current evidence with the 20 randomized control trials of more than 2,000 women searched through the February 2024, a 48% reduction of preeclampsia. The WHO aims the project by 2022 formally to identify L-arginine as one of the 5 high potential medicines for the preeclampsia prevention globally. So the calcium, coming to it, is usually the most underused intervention in the prevention of preeclampsia. So the studies show that there is a reduce of up to 55% with calcium deficient population can be NNT of 20. And mostly the recommended dose is up to 1000 milligram per day, but most of the survey conducted by WHO showed that it was less than 200 milligram dietary intake per day. And those population who are deficient are recommended up to 2 gram per day dose. So the mechanism, we are well aware, decrease in a parathyroid hormone secretion, decreasing the vascular smooth muscle contraction, suppresses the renal angiotensin aldosterone system, and resulting in the calcium-dependent vasodilation, and thus reduces the platelet aggregation. There are other trials published in 2018 shows that 55% reduction of preeclampsia was noted when calcium was supplemented in the calcium deficient population, and hence resulting into decreased severe maternal morbidity. WHO multicenter trial was conducted on more than 8,000 women, shows comprising 5 LMICs countries showed a significant reduction of preeclampsia in the nulliparous and confirmed the population specificity of the effect. There is no benefit of calcium replete moment, only the dietary deficiency worked in published in 1997, quite old study though. Another 2015 study showed the combination statistically super to either the monotherapy and as a calcium and aspirin for the preeclampsia treatment. Looking into the other targeted supplement, the vitamin D can be given throughout the pregnancy with a dose of 1000 to 2000 international per day. It regulates the vascular endothelial growth factor with SFLT1, immune tolerance with the best trophoblast gene expression, and better calcium absorption. It is recommended in many of the guidelines. Coming to omega-3, the recommended dose is up to 2.7 gram per day from 12 to 20 weeks onward. Again, it functions to decrease the TXA2, increase the PGI anti-inflammatory effect, and resulting into decreased platelet activation and hence better placental perfusion. It is noted in one of the studies that decrease in a preterm was noted when omega-3 was given before 34 weeks. So less NICU admission, less morbidity to the newborn. The folic acid in a high dose is recommended up to 4 to 5 milligram per day. That include the preconception and the first trimester period, resulting into the decrease in homocysteine, endothelial toxin, increased methylation, and decreased oxidative stress. A study of 2016 published showed a 4 gram per day subscription of the folic acid trend decreases the early onset of the preeclampsia benefit, especially in the high-risk population group, and also added benefit of preventing the neural tube defect. It is not recommended to give vitamin C and E during pregnancy in any of the trimester. Coming towards the combination protocol of the aspirin and calcium, this is a minimum of the standard. Zaho in 2015, a meta-analysis showed the combination that is statistically superior to either alone. The NNT goes down. This is what every high-risk woman in a calcium-deficient population should receive. Coming to the aspirin and L-arginine, the Vidalo trial show the additive benefits of combined L-arginine. It is basically the two different pathway, no overlap, no interaction, optimal combination for the high-risk woman. And the triple therapy of aspirin, calcium, and L-arginine. Together, however, no randomized control trial has yet been published. For the trial of aspirin and a vitamin D deficiency, enhancing the KOGS2 anti-inflammatory. So it is an ongoing. The results are expected in the upcoming years. The pitfall that does not work is the vitamin C, E, not recommended, and the calcium supplementation in a calcium replete population is not. Aspirin after 16 or maximum later on 20 weeks does not show any added benefit on the studies recorded, and a progesterone also has no role in the prevention. This is the summary of table. All at once is a low dose aspirin up to 100 to 150 milligram can be prescribed ideally by 16 weeks of the gestation and decreases the 62% early onset of the preeclampsia. Similarly, calcium up to 2 gram per day by 20 weeks decrease of 55% calcium deficient population for developing preeclampsia. L-arginine can be up to 3 to 6 gram in a divided doses between 14 to 32 weeks can be given. And vitamin D, omega are the same doses I discussed previously. If I compare the high-income countries to LMICs and South Asian, my country, the screening is the clinical factor that only uterine artery Doppler index for the PI at 20 to 24 weeks is available, and PIGF facility is hardly available in less than 10% of the facilities, so difficult to screen early and to prevent early intervention. However, the compliance is noted poor for the aspirin, and again, there is a poor antenatal follow-up visit, so mostly the patient missed to be prescribed timely recommendation of the aspirin in the high-risk population. Same is for the nutritional element related to the calcium during the survey conducted. However, L-arginine is one of the most evidence-based recommended nowadays that is a cheap, least side effects, almost not documented yet, recommended in a high-risk population who present bit late, but still better to offer them rather than doing nothing. Getting into the summary of what to do during the first trimester between 8 to 12 weeks is the assessment and initiation, as every contact of during the antenatal care matters, is the risk stratification for the moderate to high risk, especially for those who are nulliparous, BMI of 30 and above with a family history, and could be the Asian ethnicity as well as a high risk. Now consider times starting the aspirin at least 150 milligram at night, or in some countries 100 milligram is only available preparation, so it is also acceptable. Start the calcium 1.5 milligram gram per day, splitting into the 3 doses for those who have issues with the tolerance or GI upset can be. Folic acid 5 gram per day along with the vitamin D of 1000 international unit, which is commonly prescribed in Pakistan, and booking the uterine artery Doppler by 20 to 24 weeks. At 14 to 28 weeks, it is the time for to augment and monitor, confirming the aspirin has been started, ensuring about the compliance. If there is a need and a high-risk population with a previous history of the preeclampsia, CKD, or abnormal PI of the uterine artery Doppler, adding arginine could be beneficial. If there is a poor dietary intake, omega-3 up to 2.7 gram per day could be added. Uterine artery Doppler with a bilateral notching escalate the surveillance fortnightly as in the recommendation. Target BP should be less than 140 by 90 mm of mercury. 28 to 36 weeks is the monitor and a planned delivery, fortnightly BP monitoring, close follow-up, stop the aspirin at 36 weeks, and the ratio of less than 38 has a high negative predictive value. Delivery planning if FGR is abnormal, Doppler, or raising the BP trends based on the maternal or the fetal situation. So mostly in some of the setup, we encountered the barriers regarding the compliance, that I was unable to take the medicine, I forget. So nighttime dosing routine, full alarm, pair with the teeth brushing could be beneficial in counseling. Sometimes the patient complains regarding the aspirin to be taken with food if they have a stomach upset or there are myths about it, cannot take on empty stomach, and calcium carbonate with the meals could be added. Some says that reference to their family members who took the aspirin but still had the preeclampsia, but we still need to counsel them, explain it directly that it reduces the risk of the serious illnesses in pregnancy and is the mode of prevention, not for the treatment. So as far as affordability, it is very cheaply and easily available over the counter as well in many countries, including Pakistan. So for the harm regarding to the baby, it is definitely not harming the baby. It has a very safe data available worldwide. What next decade of prevention strategies could be into the precision of the medicine, looking into the AI, the biomarkers, and the global equity. Looking into the biomarker is the precision prevention dosing using the ratio of the SFLT1 and PIGF, individualized aspirin and L-arginine doses as already beginning, and pharmacogenomic testing for the aspirin resistance could be noted is of the great value, and 25% of the women who do not respond due to KOGS1 polymorphism is in active trial according to the available data. Second is the new agent. The STAMP trial is testing the provastin. The STRAPS is testing the metformin, vitamin D, combining with the aspirin. Hopefully, the result of these guidelines will be available. These are the clinical trials. Then AI screening machines combining the Doppler, PIGF, and proteomic data is achieving over 90% detection rates of an electronic antenatal care decision support is being piloted in countries where there is poor facility for close follow-up. So electronic antenatal care would help. L-citrulline, the precursor of the L-arginine, is the superior oral bioavailability, may replace the L-arginine in the next generation of the protocol based on the data published in 2025. So, conclusion to this is that aspirin remains the cornerstone of the prevention of preeclampsia. However, there is incredible evidence available for the start of the L-arginine between 14 to 32 weeks, and calcium is a globally underutilized drug. However, the benefits has been up to reduction in 50% of the prevention in preeclampsia, and combination in the future could be use of the aspirin, calcium, and L-arginine to add the added benefits. What does not work is the vitamin C and E. Reported study shows the harmful effect, and we look into the biomarkers guiding the doses, AI risk prediction, L-citrulline use, and hope to have results soon. Thank you.
Thank you so much, Dr. Muslim. It was a very interesting topic lecture. We have one question in the panel. It says from Dr. Suraya Awal. Thank you, Sarah. In these studies, what level of serum calcium was considered low? What form of calcium was administered? And is there an updated preferred form to be used?
It was 2022 survey conducted by the WHO in Pakistan that shows that mostly the women have low intake of the calcium in their diet, and it was diagnosed with a bone density test and then followed by the serum calcium levels as well. So on the survey, it was probably LMIC's a multi-country survey, so showed that providing the daily intake of up to 2 gram of the calcium per 1000 milligram of the calcium per day in the dietary in the form of the high dose calcium supplement could have an added benefits.
Thank you. I also have one question. In low and middle income countries where nutritional deficiencies are more prevalent, do you think that calcium and L-arginine supplementation should play a larger role than currently international guidelines?
Yes, in fact, there are many studies that has been conducted, and I have my own clinical research with the collected data of about 72 patients. But actually, the problem remains that with the follow-up. So once we subscribe the patient but lost to follow-up or maybe move to another city. So to the 72 patient which I collected the data, even starting L-arginine in the late second trimester or early third trimester had shown a benefit in the improvement of the quantification of the amniotic fluid volume. And there are other tertiary care hospital who which published the data that betterment of oligohydramnios with the use of the L-arginine. Then for those who want to prevent it, although the recommendation shows to start it after second trimester, but no harm was up till noted for those, or there is no reports available, even if the patient has taken in during the first trimester. So in Pakistan, many centers, especially the tertiary care, as IUGR, the NICU facilities, and other less invasive or the invasive testing is less available However, the obstetrics is the most overburdened cases, so definitely it is of the benefit from the research already published.
Thank you very much, Dr. Muslim, for your excellent and insightful presentation. You have provided us an important overview of the evolving landscape of preeclampsia prevention and highlight the need to consider prevention strategies beyond a single intervention. Your discussion of calcium, L-arginine, target supplementation, and personalized approaches has encouraged us to think about how we can further optimize prevention strategies based on evidence and individual patient risk. Thank you for sharing your expertise and for contributing to this important area of maternal fetal medicine. We will continue with our next speaker.
Yes, and we will now move to our final session, genetic research and global perspective. For this reason, we are delighted to welcome our next invited speaker, Dr. Francisca Javier Ruiloba Partila, a maternal fetal medicine specialist dedicated to advancing women's health through clinical excellence, education, and international collaboration. Dr. Ruiloba has held leadership and editorial roles within FIGO, WATOG, and the International Journal in Gynecology and Obstetrics. He is currently a fetal medicine fellow at the Fetal Medicine Foundation, and his work focuses on maternal fetal medicine, global obstetrics, reproductive health, and medical education, with a strong commitment to promoting equitable, evidence-based maternity care and supporting the development of the next generation of obstetricians and gynecologists worldwide. We are honored to have Dr. Ruiloba with us today and look forward to his valuable insight. Dr. Ruiloba, the floor is yours.
Hasmik, do you see him connected?
Yes, he said that he's in. Let me check.
Yes, that's why maybe he got lost the connection or something.
Maybe, yes.
Mm,
Because 2 minutes ago, he says that he is in chat.
yeah, but now cannot find it among the.
Yeah.
Maybe I have the honor to follow with your. In the meantime, what do you think? Let's wait 2 minutes and then.
Let's wait 1 minute and then I will continue.
Yeah, perfect. What the second day, really. Very deep dive in fetal maternal medicine, I think. Very interesting and a high level evidence provided till now about all this calcium and aspirin and fetal restriction. So we are welcoming all of you to make your comments, your thoughts, your experience back in your countries, because this is our global view. This is why we're trying all together under WATOG organization to start organizing. So I think, Hasmik, let's give some more time to Dr. Rubiola, and I'm more than honored to introduce you and welcome you as our next speaker, Dr. Hasmik Baregamyan from Armenia. She's a PhD in reproductive medicine and adolescent health. Her clinical and academic interests include maternal health, high-risk pregnancy, respectful maternity care, gynecological endocrinology, reproductive medicine, women's health. She's one person of a kind with her positive spirits and all these organization skills also. Today, Dr. Baregamyan Hasmik will present an important and rapidly evolving topic about maternal stress and fetal neurodevelopment. I'm highly interested to hear from you and learn from you, actually. And we are very honored, Hasmik. Thank you for all that you have done in collaboration with WATOG, EBCOG, ENTOG, and the Kenyan organization society. And please.
Thank you so much. Thank you so much, Dr. Sophia, for your nice presentation introduction for me. So I would like to share my presentation. My topic is about maternal stress and fetal neurodevelopment. For decades, our specialty has focused on preventing maternal complications, reducing maternal mortality, managing obstetric emergencies, preventing stillbirth, achieving a healthy birth, and improving neonatal survival. These remain our fundamental priorities. These achievements transform the lives of millions of women and children. Today, however, advances in placental biology, development, neuroscience, and life course epidemiology have extended our perspectives. Increasingly, we recognize that pregnancy is not only a period of fetal growth. It is a critical developmental window during which maternal physiology, placental adaptation, and fetal development interact to influence health across the life course. Among the many maternal influences under investigation, including metabolic health, nutrition, inflammation, infection, sleep, and psychological stress, the placenta has emerged as the central biological regulator. Today, I would like to explore how maternal biological signals are interpreted by the placenta, how these adaptive mechanisms may influence fetal neurodevelopment, and what this means for current clinical practice and the future of precision obstetrics. So, why has this topic become so important? Because maternal mental health disorders are among the most common complications of pregnancies around the world. Globally, approximately 1 in 10 women experiences antenatal depression, while clinically significant symptoms affect nearly 1 in 5 pregnant women. The prevalence is even higher in settings affected by poverty, conflict, humanitarian crisis, and limited across the healthcare. At the same time, pregnancy represents one of the most dynamic periods of human development. During these 9 months, the fetal brain undergoes extraordinary growth, while the placenta continues adapts to changes in the maternal environment. Large prospective cohort studies conducted over the past 2 decades have consistently shown the persistent maternal physiological distress is associated with most differences of spring emotional, behavioral, cognitive, and language development. However, these findings require careful interpretation. They represent association rather than causation of they cannot predict the future of an individual child. Indeed, the majority of children exposed to maternal psychological distress during pregnancy develop normally. Our goal, therefore, is not to create fear or guilt, but to understand the biology, intend women who would benefit from additional support and optimize maternal health because this benefits maternal babies and families. So the pioneering work of David Baker demonstrates that early life conditions should influence adult disease risk, particularly cardiovascular disease. Since then, the conception has expanded to include metabolic health, immunoregulation, neurodevelopment, and mental health. However, developmental origins of health and disease is often misunderstood. It does not mean that pregnancy determines a child's future. Rather, it suggests that the placenta translates maternal exposures into biological signals that shape lifelong health. If pregnancy is critical developmental window, the next question becomes which maternal factors influence this developmental environment and through what biological mechanism. So to answer this question, we now go to another slide. Stress is often considered a psychological experience. However, biological stress represents a complex interconnection between perception, the nervous system, endocrine regulation, immune responses, and the surrounding environment. It is important to emphasize that stress exists on a spectrum. Temporary emotional responses, for example, anxiety before an ultrasound examination or concerns about childbirth, it is a normal part of pregnancy. The biological concerns arises when persistent physiological distress, severe anxiety or depression, chronic adversity, trauma, violence, displacement, or prolonged social stress. This condition can activate several interconnection pathways: the hypothalamic pituitary adrenal axis, sympathetic nervous system, and inflammatory signaling. These responses may alter circulation biological mediators, including cortisol, catecholamines, and inflammatory cytokines, as Jazid Miranda says yesterday in his talk. However, one of the most important concepts is that in this field is the fetus does not experience maternal emotional directly. Instead, maternal experience are translated into biological signals, and these signals are interpreted and regulated by the placenta. This distinction protects us from an oversimplified message that maternal stress directly causes fetal harm. So, to understand why maternal signals do not simply pass directly to the fetus, we must turn to the central organ, to the placenta. The placenta is one of the most dynamic organs in human biology. It functions simultaneously as endocrine organ, an immune regulator, a metabolic sensor, a vascular regulator, and a communication interface between mother and fetus. Throughout pregnancy, the placenta continuously senses maternal conditions and adjusts its function to support fetal growth. It regulates nutritional transport, oxygen delivery, hormone production, and immune tolerance. One of the most examples of placental protection is glucocorticoid regulation. Maternal cortisol is essential for normal physiology, but excessive fetal exposure may influence developmental pathways. The placental enzymes 11-beta-hydroxysteroid dehydrogenase type 2 converts active cortisol into inactive cortisone, reducing fetal exposure. This illustrates a central principle of placenta biology. The placenta does not simply allow maternal signals to reach the fetus. It activates, interprets, modifies, and regulates these signals. But an important question arises. Does every placenta respond to maternal challenges in this way or not? One of the most important advances in developmental biology is the recognition that the placenta is not only a target of maternal influences, it is an adaptive organ. For many years, research focused primarily on identifying harmful prenatal exposures. Today, our understanding has become more nuanced. The key question is no longer simply, was the pregnancy exposed to stress? The more important questions are, how severe was the exposure? When did it occur? How long did it persist? How did the maternal biology systems respond? How effectively did the placenta adapt? The placenta possesses remarkable adaptive capacity. It can modify glucocorticoid exposure, inflammatory responses, vascular function, nutrient transport, and endocrine signaling as well. This adaptive capacity explains an important observation from human studies. Many women experience psychological stress during pregnancy, yet most children develop normally. This reflects biological resilience. However, adaptation has limits. When challenges are severe, prolonged, or combined with other factors such as obesity, diabetes, infections, inflammations, or placental vascular disease, the adaptive capacity of the placenta may become insufficient, and it depends also the phenotype of the placenta. Placenta dysfunction may contribute to pregnancy complications, including fetal growth restriction, preeclampsia, preterm birth, and altered developmental trajectories. The important message is that maternal stress is one factor within a complex biological network. If the placenta adapts the regulator maternal signals, the next question is, how does the placenta communicate with the developmental fetal brain? So this question has led to the emerging concept of the placenta-brain axis. The placenta-brain axis describes the communication network through which maternal physiology may influence fetal brain development, with the placenta acting as the central mediator. The placenta receives information from the mother environment, processing these signals and communicates with the fetus through multiple pathways. This includes endocrine signals, immune mediators, vascular regulation, extracellular vesicles, and epigenetic mechanisms. Experimental and translational studies suggest that these pathways may influence processing involved in brain development, including neuronal differentiation, synaptic organizations, microglia maturation, or neuronal connectivity. However, scientific responsibility requires careful interpretation. Many mechanisms discovers come from animal model or laboratory and systemic. Human neurodevelopment is much more complex. Children's developmental trajectories, interaction among prenatal biology, genetics, maternal health, family environment, education, nutrition, and importantly, lifelong experience. At present, the placenta-brain axis should be regarded as a powerful scientific framework, not a clinical diagnostic tool. The biology is compelling, but clinicians need to know, what do human studies actually demonstrate? So the most important question is whether this biological concept translates into measurable outcome in humans. Over the past 2 decades, several large prospective birth cohort studies have investigated associations between maternal physiological distress during pregnancy and child development. Together, these studies have provided valuable evidence that present maternal anxiety and depression during pregnancy are associated with modest differences in several developmental domains. Reported associations include emotional and behavioral regulation, attention and executive function, language development, and cognitive outcomes. More recent meta-analysis suggests that the magnitude of this association is generally small. For example, pooled analyses have reported small standardized differences in developmental outcomes, with effect sizes that are generally small and unlikely to represent large clinical effects at the individual level. This is a critical point. Statistical association does not mean that prenatal stress determines an individual children's future. The majority of children to maternal psychiatrical distress during pregnancy develop normally, typically. One of the most important lessons from developmental science is that the same exposure do not produce the same outcome in every pregnancy. Two women may experience similar physiological stressors, yet their pregnancy may follow completely different trajectories. Why? Because stress is not a single biological entity. Research are increasingly investigated maternal stress phenotypes that combine multiple dimensions: physiological distress, hypothalamic pituitary adrenal axis activation, inflammatory responses, metabolic changes, sleep disturbance, circadian alteration, and social adversity. These approaches may help explain why some pregnancies demonstrate resilience while others develop complications. However, it is essential to emphasize that these stress phenotypes remain research conception. They are not validated clinical classification. We can't currently categorize an individual pregnant women into a biological stress phenotype and predict fetal outcomes. Another important area of investigation is sex-specific placental adaptation. Evidence suggests that male and female placentas may respond differently to environmental challenges. Some studies suggest that male placentas may demonstrate increasingly vulnerability to certain adverse conditions, whereas female placentas may show greater adaptive flexibility in some biological contexts. These differences may involve sex chromosomes, hormonal signaling, immune pathways, mitochondrial function, and epigenetic regulation. However, fetal sex response is only one component of a much larger biological system. It should never be interpreted as a clinical predictor of an individual child future. Understanding biological diversity has opened the door to new technologies that allow us to study the placenta at an unpredictable level. The future of developmental medicine is increasingly focused on understanding the molecular language of the placenta. An important area is the study of extracellular vesicles. The small membrane-bounding particles are released by placental cells and contain molecular information, including proteins, lipids, messenger RNA, and microRNAs. They may participate in communication between the placenta, maternal circulation, and fetal tissue. Another major research area is epigenetic. Epigenetic mechanisms regulate gene activation without changing the DNA sequence itself. Researchers are investigating whether prenatal exposure influences pathway involving in glucocorticoid signaling, stress regulation, neuronal development, and immune function. The maternal microbiome represents another emerging area. Microbial metabolites may influence maternal immune and metabolic pathways and potentially interact with placental biology. Finally, advances in signal cell transcription, multi-omics, digital health, and artificial intelligence are creating new opportunities for precision obstetrics. However, we must maintain a scientific discipline. These technologies are promising but non currently provided as a validated clinical test that can predict an individual's children's neurodevelopmental outcome. The future is exciting, but it is require careful validation before clinical implementation. After considering this emerging mechanism, the most important question arises: what can we actually do today for our patient? Despite remarkable advances in prenatal biology, our most powerful interpretation today remain remarkable practical. Although we do not have a validated placental biomarker that can predict future neurodevelopment, we may not be able to identify which fetus is vulnerable to stress-related development differences, but we do not. We do have evidence-based approaches that improve maternal and family health. Professional organizations recommended approaches, psychosocial assessment during pregnancy using validated tools associated to local healthcare system. Examples included Edinburgh Postnatal Depression Scale, Patient Health Questionnaire 9, Generalized Anxiety Disorder 7. However, screening alone is insufficient. A possible screen should lead to clinical assessment, appropriate referral, psychosocial support, psychiatric care when indicated, and follow-up. Evidence-based intervention included a cognitive behavioral therapy, treatment of clinically significant depression or anxiety, physical activity, sleep optimization, strengthening social support, and addressing social determinants of health. Importantly, our goal is not to eliminate all stressors from pregnancy. That is impossible. Our goal is to identify suffering, reduce preventable harm, and create conditions that support maternal and fetal health. When discussing maternal influence on fetal development, psychosocial stress is only one part of a much broader biological landscape. Another important and potentially modifiable factor is sleep. Sleep disturbance is extremely common during pregnancy due to hormonal changes, physical discomfort, anxiety, fetal movement, and preparation for motherhood. Sleep is not simply a period of rest. It is a biologically active state involving neuroendocrine regulation, immune balance, glucose metabolism, cardiovascular function, and circadian rhythm regulation. Emerging research suggests that maternal circadian rhythm interact with placenta, clock genes, and a fetal biological rhythm. Disruption of these pathways has been investigated in relation to metabolic complications, inflammations, and pregnancy outcomes. However, similar to stress research, we must interpret these findings carefully. Although improving sleep clearly beneficial and have benefits maternal health and well-being, so we do not yet have sufficient evidence to conclude that sleep interventions prevent specific neurodevelopmental disorders in offspring. Therefore, sleep assessment should be viewed as a part of comprehensive antenatal care, not as a tool to predict fetal outcomes. As our knowledge expanded, we must also define the boundaries of what science can currently tell us. One of the responsibilities of modern medicine is not only to communicate discoveries, but also to communicate uncertainty. The science of developmental origins is powerful precisely because it is complex. Let us distinguish established evidence from unanswered questions. What do we know with confidence? What we know that maternal mental health is a fundamental component of antenatal care. We know that persistent psychological distress is associated with increased risk of several adverse maternal and child outcomes at the population level. We know that the placenta is an active biological regulator of maternal-fetal communications. We know that early identification and treatment of maternal mental health conditions improve maternal well-being. But there are important limitations. Current evidence does not support the conclusion about maternal stress that maternal stress causes autism. Maternal anxiety determines attention deficit and hyperactivity disorders. One, a stressful event damages the fetal brain. Cortisol testing predicts a child's future or not. Ultrasound or fetal MRI can diagnose fetal stress or injury. Placental biomarkers are ready for routine clinical use. We don't know. These limitations do not reduce the importance of this field. They define the direction of the future research. Today, maternal fetal medicine is entering a new area. The future is unlikely not depend on one single biomarker or isolated measurement. Instead, precision obstetrics will integrate multiple layers of information: maternal clinical characteristics, psychosocial assessment, placental biology, fetal imaging, genomics, transcriptomics, metabolomics, digital health, and artificial intelligence. The goal is not to predict the child destiny. The goal is to early recognition of vulnerability and more personalized support. However, innovation must always be accompanied by responsibility. Before new technologies enter routine care, they require prospective validation, demonstration of clinical benefit, ethical oversight, equitable access, and cost-effectiveness evaluation. The future of obstetrics will not be defined only by technology. It will be defined by our ability to combine scientific discovery with compassionate clinical care. After exploring the biology, evidence, and future direction, I would like to finish with the practical message we should carry into clinical practice. I would like to conclude with 5 key messages. First, pregnancy is critical developmental window during which maternal biology, maternal physiology, and fetal development interact to influence lifelong health trajectories. The placenta is not simply a transport organ. It is an active biological regulator that sends, adapts to, and modifies maternal signals. Third, maternal stress is an important biological influence, but it is not deterministic. Developmental reflects interaction among maternal health, placenta resilience, genetics, fetal susceptibility, and the potential environment. Part 1, the most evidence-based action available today is to recognize and support maternal fetal health through comprehensive, compassionate antenatal care. Fifth, fifth one is the future of maternal fetal medicine lies in integrating developmental science, placental biology, and precision medicine while maintaining scientific responses. And finally, every pregnancy represents an opportunity not to determine a children's future, but to create conditions that support health development. Thank you very much for your attention.
Thank you a lot, kind Hasmik. Thank you very much, Dr. Barekiamyan, for this very interesting and highly evidenced presentation. You are very well described to all of us the complexity of the relationship between the maternal environment, the placenta biology, and the fetal neurodevelopment. It was a very complicated, but you show us how important is the good start for the lifelong brain health, as you see in your last slide that you can see already. Thank you a lot for sharing your experience and contributing to this important area in maternal fetal medicine. And in order to just let you take a breath from all this long and very nice presentation, let's see if Dr. Rubiola is now here among us. Yes, I think that he's logged in, he's connected, perfect. So, Hasmik, do you want to present him or how do you want to continue?
He said that I'm connected already, but I would appreciate if you went first. So I did it.
Yes, perfect.
Oh, so Ben Ruloba is here. Francisco Ruloba.
Dr.
Give me
Tigran
access.
Isakianian.
He wants to give him access.
Okay, perfect. So, Dr. Tigran Insakian, you are the sixth speaker. Let Dr. Rubiola first to get connected as he was the previous one and he's wanted also to get access. Maybe we can have the support by Dr. Aida. Linda, can you please help us with the permission and the technical support?
Maybe Tigran will close his presentation.
Please stop sharing. Thank you a lot.
Sorry.
No, thank you a lot. No, it was our mistake actually. Thank you, Prof. So let's see.
Dr. Aida, are you here?
No, Aida.
Okay, I will write.
Yes, she's connected. She's among us. And if you hear us, Linda, can you please make co-host Dr. Rubiola in order to let him give his presentation? Maybe Hasmik, we should also continue with Dr. Ter Isakianian.
No, just give me access.
Ah.
He says Francisco Rolapa is ready, but
Yes, perfect. So you can present Dr. Viola in the meantime, I think.
I just sent a message to Aida.
She's working on it. She puts in our chat. Okay. She wants more time. Okay.
Dr. Rolapa, nice to meet
perfect.
you.
Here I am. How are you guys? Nice to see everybody.
We are delighted to welcome our best invited speaker, Dr. Francisco Ruiloba, a maternal fetal medicine specialist dedicated to advancing women's health through clinical excellence, education, and international collaboration. Dr. Ruiloba has held leadership and editorial roles within FIGO, WATOG, and the International Journal of Gynecology and Obstetrics. He is currently a fetal medicine fellow at the Fetal Medicine Foundation, and his work focus on maternal fetal medicine, global obstetrics, reproductive health, and medical education, with a strong commitment to promoting equitable, evidence-based maternity care and supporting the development of the next generation of obstetrics and gynecologists worldwide. We are honored to have Dr. Ruiloba with us today and look forward to his valuable insight. Dr. Ruiloba, the floor is yours.
Thank you very much, Hasmik. Can everybody hear me there? Yes. Perfect. Thanks a lot. I just wanted to say congratulations to Hasmik and to all the team for organizing this. I think you just did such an amazing job. You got us all together. You decided these topics, and I think it's been so good. Thank you so much for this. I am extremely grateful. So, without further ado, today I'm going to talk to you guys about NIPT. Over the next 15 to 20 minutes, I want to tell you the story of NIPT very quickly because it's not so long, it's actually quite new, but it is quite a story how a single tube of blood completely changed prenatal genetics and fetal medicine. And we will also talk about how it's a very misunderstood test and it gets misread in the clinics every single day. No, so we're gonna start with a clinical case. So imagine this: a 29-year-old patient. It's her first pregnancy. She goes to your consult. She has no risk factors. She did have ultrasound where they told her everything was fine, but then her friend told her to go get an NIPT because it's today's fashion. No? So she goes to the laboratory and she gets an NIPT, and suddenly, boom! High risk for Down syndrome, no? So she comes to you, you are the maternal fetal medicine specialist, you're sitting in your desk and you are thinking, what should I tell this patient? Does her baby have yes, Down syndrome, no Down syndrome, probably yes, or probably not? So what do you guys think this question is? It came out as high risk for trisomy 21, no? The patient tells you, well, I heard that this study is 99% accurate. So she's crying. The patient is very scared. So what does NIPT tell us and what does not? And the answer, against all of your instincts, is that it's probably not. And why? No, this is what we are going to explain today. This is most of our talks. So for decades, a genetic answer meant doing an invasive procedure, having to do either the CVS or an amniocentesis, and then you had to wait for the karyotype. It was diagnostic, it was definitive, but it came wrapped in a fear, the fear of causing a miscarriage. And you know that as trainees, you have been told these numbers many times, and maybe you have told it like to the patients, like, guys, you know that if you do an amnio, it's 1 in 200 risk, or in some places say 1 in 100 risk of having a pregnancy loss. And this obviously frightened the patients because patients say like, obviously I don't want to lose my baby. What if I'm doing a scan and I want to know if it's high risk, and then I want to have an invasive procedure, but it's 1 in 100. That number is too high, so I don't want to go for the CVS, no, or for the amnio. And this is a number that I want to retire today. This myth. Most of us were taught that date, but the best current data from 2019, a meta-analysis from Salomon et al. Showed that the risk in expert hands for an amnio for pregnancy loss is 0.1%, and the risk of CVS pregnancy loss is 0.2%. Why does this matter? It matters because the value of a screen that lets you avoid an invasive test, no? Like the combined screening or the NIPT. It's a screen test that if it comes back as low risk, you should have to know with enough certainty that you can probably avoid an invasive test. But it's also true to like the flip side, no? Because the diagnostic procedures are now demonstrably and very quite possibly safe, then confirming a positive screen is also cheap in terms of risk. So please do not talk a woman out of her amniocentesis or her CVS when she's high risk in the combined screening just because of the NIPT looks reassuring. No, the old figures, we have to forget about those and start talking about the next ones. Now, that being said, we have to start talking. We're going to divide this talk in 4 parts. We're going to go first from the karyotype, which was the old paradigm, to the cell-free DNA. No? Before the cell-free DNA existed, we already had a way to be smart about who got the needle. No, it's the combined screening test from the Fetal Medicine Foundation. The combined screening test, you know this, you probably do it in your hospitals. It uses the maternal age, the nuchal translucency of the baby, the HCG, and the PAP-A. That's the model the FMF has. It's validated, and it's still the backbone of the screening in most of the world, no? And the performance of this screen is around 90% for trisomy 21, and the false positive rate is at around 5%. It's actually a very good screen. But stick with this 5 false positive rate number in your mind. This means that 1 in 20 patients that you screen, who you tell them that she's high risk, is a false positive, no? And the large majority of those are false alarms. Each one of these is a patient who is very anxious, who may head for an invasive test that she probably did not need. That 5% is the place where the NIPT is going to work on the best, no? It's the problem that NIPT is going to solve. And, of course, if we add from the combined screening test, we add the nasal bone, the ductus venosus, the tricuspid regurgitation, it pushes the detection rate to about 93 to 96%. And the false positive rate, it lowers to around 2.5 to 3%, no, in expert hands. So this means that is the combined screening test obsolete now that there is cell-free DNA? Well, obviously not, no? First trimester scan screens for so many much more things, and we're going to talk about them in 1 minute. Then the paradigm that changed everything. In 2011, the field completely changed because the maternal plasma was turned up to be full of these short fragments of cell-free DNA. At the beginning, well, everybody says fetal DNA, but in reality, it's not fetal DNA. It's placental DNA. No, there are small pieces of the DNA from the placenta that are swimming inside of the maternal plasma. This is important, so you can remember it. No, a fraction of them comes from that placenta, so that's called the fetal fraction. The fetal fraction, and you can count these chromosomes carefully in the DNA, and you can tell if there is an extra chromosome or not, only from a blood draw, no? And this can be done starting from 10 weeks. So this is the most important piece of biology in the talk, is that it comes from the placenta, not from the baby. And when the baby and the placenta do not match, which is the confined placental mosaicism, which is very important, the blood test can be wrong. That's one of the limitations of NIPT that we're going to talk about. The fetal fraction, normally it is around 10%. It increases with the gestation. Obviously, it falls with the high maternal weight, with a high BMI, and it also falls down with the trisomies, no, with the common aneuploidies, no, 18 and 13. So that's why we're going to talk about the no-call results in a minute. And we're going to see that the gestational, the fetal fraction rises throughout the gestation. And then after the pregnancy is over, the fetal fraction, in a matter of hours, just goes to levels that are almost to zero. So this is very important because this means that In another pregnancy, we won't have DNA from the previous pregnancy. No? One thing that is true already and that we know is that NIPT is exceptional for the three most common autosomal aneuploidies. No? Cell-free DNA beats every single screen before it. From the Fetal Medicine Foundation's own meta-analysis, comparing it also to the combined screening test, even with the markers and everything, this is the best, like the screening test for these three aneuploidies. For trisomy 21, we can see that it's 99.7%. Trisomy 13 is also on the high 90s, and trisomy 13 just a little bit less. But the word that matters here, and I underlined it, is screen. No, it's not diagnostic. And we're going to talk about how this screening precision that we're talking about, this detection rate, does not take into account the pretest probability. And that's the most important thing that we're going to talk about today, no? So we said NIPT is a screen. It's definitely not a diagnosis. The sensitivity and the specificity are things that people talk about when they're talking about a test. But the number that we always have to look at is the positive predictive value. The sensitivity and the specificity are things that will not change. But what a positive result means for any given woman depends on something that the test, that the laboratory does not know anything about. Her prior probability, no? The pre-test probability that affects the positive predictive value. So how likely a woman is to be carrying an affected fetus before we actually take the blood from her, no? For example, we take an older patient, no? Take a patient with a high nuchal translucency, a patient about 40 years old. This is a patient that will have a high prior probability. A positive result here is very likely, no? And the predictive value can rise all the way up to 85 to 90%. Now, take our 29-year-old woman that we talked about in the first slide. She's young. She had a scan that she says that everything was fine. The same test that we do on her, same accuracy that we talked about over here in the previous slide, but it's a completely different positive predictive value because she has a very low pre-test probability. Because trisomy 21 is rare on her, as half of positive results are false alarms. Imagine that. So in reality, this patient that we talked about in the first slide, whether her baby or not has the Down syndrome, is literally like a coin toss. And this patient was already in your office. She was crying, and you're telling her, well, you're low risk, so the pretest probability is also very low, no? In these very large studies, the CARE study, the general risk in a mean age of 29, just like our patient, that's why I chose her to be like this. The positive predictive value was 45.5%, so less than half. In the next trial, another big study, in this same age, it was 81%. So even these differences show that there's very different in different populations. There's different prevalence of aneuploidies, and that talks about the pretest probability, and that's gonna impact directly on the positive predictive value, and therefore it's the number that we have to look at. No, it's not the accuracy that everybody sees like, oh, 99% accurate. No, the number that should be written big and red on every single NIPT that we perform is the positive predictive value, no? When can this blood be misleading with discordant and failed results that they're not random? Each one has a certain biology behind it. So it's not like, for example, when you're in your house and the Wi-Fi doesn't work and you just turn it off and on and then suddenly it works again. This is not like NIPT. This is not how NIPT works. You just, if you get a no-call NIPT, a discordant result, it's not like you just have to take it again without thinking. You have to think, why is it discordant? Why was this result not conclusive? Sometimes it is because of low fetal fraction. So you have to look at the number of the fetal fraction that is displayed in the test that you took. And you have to know that high BMI, early gestation, small placentas, as we were saying in these aneuploidies, they all will also have low fetal fraction, no? Then we also talked about the confined placental mosaicism, that it might be different, the DNA from the placenta than from the baby. The vanishing twin, DNA from a demised co-twin lingers in the plasma for weeks, and it mimics a fetal aneuploidy in some cases. So NIPT is not equally as valid in patients that have a vanishing twin. And finally, the maternal findings, the mother herself, no? The maternal copy number variants that she may have, or rarely an occult malignancy. We're going to talk about that, but women that have cancer may have a no-call NIPT, which is something that is pretty shocking. So it's a no-call when we get it. It's just not just a redraw. A failed test is associated with a higher aneuploidy. And for example, if we had the patient from the first slide, and instead of having a high risk for Downs, she came with a failed test, well, that also increases her risk of having trisomy 21, no? Because trisomy 13, trisomy 18, and also triploidies tend to have lower fetal fraction. So a no-call warrants review, warrants to ask ourselves why, a scan, counseling, it's very important, no? And also there are other things that a blood test, the NIPT cannot see, no? The cell-free DNA screening complements ultrasound. It does not replace it at all. The first trimester ultrasound is still the backbone of the screening, no? The reassuring NIPT tells you the common trisomies are probably fine, but it does not tell you anything about how the baby is built, all of the anatomy, all of the other rare syndromes that we might describe in the first trimester. In the first trimester scan, we can say, oh yeah, low risk NIPT, and then the baby has, I don't know, spina bifida, holoprosencephaly, so many things that can be detected by an early anatomy scan that NIPT just cannot do. So we talked about these big three aneuploidies, no? Now let's go beyond, no? We're talking about now a little bit of the present, and when we go to the fourth part, we're going to talk about the future. Beyond the big three, no? It's obvious, like, once you can count the common trisomies this well, the temptation will be like, okay, let's start looking for other genetic things, no? The industry, the patients, everybody starts pushing you, no? What about other syndromes? And it's always something that we have to ask ourselves, no? For example, sex chromosome aneuploidies, which is also counting chromosomes, no? Turner, Klinefelter, the triple X, XYY. The predictive value here is lower, and it's important that we know that. And it's important to know that the phenotypes here are much more variable. Many are mild, some nearly are silent. And there is a specific confounder, the maternal sex chromosome mosaicism. When women become older, a lot of them, they lose an X chromosome in a fraction of their cells. And this can give you this can be a confounding factor to screen for some of these sex aneuploidies, no? Counseling is harder, and the consent has to be given, and the counseling has to be very targeted with these patients. And this is what we have to talk about, no? More targets, lower yield, no? The rarer a condition is, the less prior probability a patient is going to have for that specific condition. It's obvious, no? So the predictive value collapses even when the assay performs well, even when the test is perfect. For example, the George, no? The 22q11, it's typical, no? When we see an ARSA, when we see a heart defect, we want to rule out the George, and patients ask you, can't the cell-free DNA do that? Well, the pretest probability is around 1 in 2,000 for the George. So even a good test applied to something that is rare gives a positive result, more likely to be wrong than right. So more is not always better. And the genome-wide cell-free DNA and the rare autosomal trisomies are still under investigations. And in the ISPD own words in 2023, they say that the evidence is not here yet for the routine use, no? Every positive on an expanded panel has to be confirmed with a diagnostic test and with microarray. So it's a screening. You do not never act on an NIPT, no? Um, and then also, the more you look, it's very obvious, no? But the more you look, the more you find, including things that you were never meant to find. And this is what happened with the NIPT. Some things you start finding out about the mother and not the baby, no? For example, I remember in the FMF Congress in Lisbon 2 years ago, having the whole audience gasp as Bianchi, a researcher, started saying that whenever she had a repeat no-call NIPT on patients, and she investigated good fetal fraction, everything was perfect with the study, and she had a no-call twice. They did a complete full-body MRI scan on them and a complete assessment to look for different types of cancer. And they found that 50% of women that had a repeat no-call NIPT had a form of cancer within the first year. No, so it's a whole thing. And the patients that got this first NIPT, they never consented for this, knowing that they were gonna have cancer. What if they didn't want to know if they had cancer or not? So we're discovering things here that we did not know that this test was powered for, and it's something that is quite shocking. And the counseling has to be done by experts, no? What about the future? No, everything so far has been about counting chromosomes, but the next decade is more about reading genes. The single gene NIPT is already here for paternally inherited conditions and also for the novodominant conditions, which are things that you do not typically find in the maternal DNA. This is what it's already being researched about, and it's already being performed in some research centers, no? Expanded recessive panels, screening parental carriers, and then inferring the fetal genotype non-invasively is something that is not so well known yet, but we're working on it, no? And from the fetal exome, from the plasma, the whole exome cell-free DNA analysis, moving from the proof of concept towards the clinic, it's something that is very promising, and it's something that we're going to start looking at for the next 10 years, no? And obviously, as the questions get bigger, well, the counseling should also get more profound. And we should, as trainees and maternal healthcare specialists, we have to know when to tell patients what does a no-call mean, what does her results mean in the NIPT, no? So also something that's very important is that not only the things that are being researched are the future of NIPTs. The future of NIPT is already here, no? Some of the cell-free DNA biggest questions are already here. For example, the RHD genotyping is already being performed in many places, like in Nordic countries or in some places in the UK. With the cell-free DNA, you can actually know the RHD of the baby. You can know if the baby is, if the mother is negative. You can know the baby's blood type, and then you can know if you have to administer the anti-D vaccination, thus saving many women from unnecessary treatment. And the fetal sex, it's also something that is already here. It has to be one has to be very careful with this, but it's already here, and the sexual chromosomes are also being counted, no? As always with the future, the real frontier is access, and this is why I'm sure HASMIC was wise enough to organize this worldwide Congress, because we're people from all over the world here, and NIPT is unfortunately not yet a reality in most of the world. No, in high-income countries, it's already part of national programs. In many places, they go straight to the NIPT for every single woman. But in some other places, they do the combined screening test first, and in some places, the NIPT just hasn't reached there. No, the technology is racing ahead, but the access and the equity care is not racing as fast as technology in most of the world. No, so I have 4 conclusions to tell you for you to carry into your clinic. Number 1, NIPT is the best screening tool we have for the common trisomies, but it's a screen, it's not a diagnosis. Number 2, what a positive result might mean depends completely on prior risk. And that's why the ultrasound is there, no? So confirm before any irreversible decision. a YouTuber, I don't know if you saw on Twitter, like they started saying like that a YouTuber had interrupted a pregnancy based on only an NIPT. Later they confirmed that it was not the case, but many people feel inclined to do this, no? They see a high risk result, they think that the pregnancy is practically over, and it's most likely not even the case, no? Number three, expanded panels add targets faster than evidence. So you have to counsel first. You have to tell the patient what this test is. You have to take the time to tell them, and then tell them that if the result comes back as high risk, then it's not a diagnosis, and then you have to run a further diagnostic test, no? And then finally, the future is single gene cell-free DNA, but most important, and I think this is something we should all focus on, is the equitable access. Not simply saying more and more chromosomes, oh yeah, technology. It's rather having the technology reach out to everybody, no? I leave you here with this slide, my professional Instagram, so you may follow me, and my email in case you have any personal questions that you don't want to ask over here, you can just email them to me. And finally, we are doing a special issue. I am running it along with my co-editors Anita Barisic and Daniel Rolnick, a special issue on NIPT. So if you guys are working on NIPT or know somebody who is working on it, just tell them that we're running this special issue. We hope to get many, many papers, and we hope to publish the best ones to deliver an amazing special issue. I was going to put out the link for the call for papers, but I don't have it here. But if you Google IJGO NIPT call for papers, it'll be the first result. Thank you very much for your attention, and I don't know if we have any time for questions, Hasmik.
Now speak your microphone mute.
Sorry. Yes, we have time for the questions. I will check if we have any question. Before checking this, I have one question for you. Dr. Ruilova, in your clinical practice, what is the most common misconception that pregnant women have about NIPT, and how do you address it during counseling?
Well, I would say the most common one is thinking that it's a diagnostic test, no? But I think I'm going to answer also another question that you did not ask. The most common misconception among us obstetricians is that it is fetal DNA that is swimming in the maternal plasma instead of the placental DNA. Because the most likely reason why you might have a false negative result is the confined placental mosaicism. It's from 1 to 5%. So it's very important to know that it might be in the placenta, but not in the baby. And that's one of the things that you have to explain to the patient, and that's why you have to do the confirmatory tests, no, the invasives. But yeah, patients come with many, many misconceptions, no? They think that because the cell-free DNA told you low risk, they think it's low risk for everything. They think that they don't need an ultrasound because somebody told them that it's 99% accurate. So that means that the baby does not have any genetical problems, which is obviously completely misguided. And it's our job to counsel the patients better, no?
Yeah. Thank you so much. Thank you, Dr. Ruilova, for being with us, for sharing your excellent, comprehensive presentation. You have provided a valuable overview of how non-invasive prenatal testing has transformed our field, fetal maternal medicine field, and changed the way we approach prenatal genetic assessment. Thank you for being with us.
Thank you, Hasmik, and thanks to everybody from the organizing team.
Well, we're moving on to our last speaker, we'd like to welcome Dr. Tigran Isahakian, who is an assistant professor at the Department of Obstetrics and Gynecology #1 at Yerevan State Medical University and a specialist in obstetrics, gynecology, and urogynecology. Dr. Isahakian has more than a decade of clinical expertise and has developed expertise in pelvic floor disorders, urogynecology surgery, and comprehensive women's healthcare. He's actively involved in medical education and international collaboration and represents Armenia as a regional representative in WATOG. Through his academic, clinical, and historical work, Dr. Isahakian is committed to improving quality of care and promoting evidence-based approaches in obstetrics and gynecology. Today, he is going to present an important topic in maternal fetal medicine, placenta-accreted spectrum, diagnosis, and surgical options. We are honored to have Dr. Isahakian with us today, and we look forward to his valuable insight. Dr. Isahakian, the floor is yours.
You are muted, Tigran.
Okay, sorry. Thank you, Dr. Leopoldo, for introduction, and thank you to all speakers for amazing lectures. It is great pleasure to speak on this platform. So we can start it. Placenta-accreted spectrum disorders are conditions that have a major impact on patient quality of life and on the course of pregnancy. Placenta-accreted was first described approximately 80 years ago. Today, however, incidence has increased several fold. Placenta-accreted spectrum results from abnormal trophoblastic invasion into the ureter wall. The spectrum includes placenta-accreted, the chronicle villi attached directly to the myometrium, placenta increta, the placenta will invade deeply into the myometrium, placenta percreta, invasion goes through the myometrium to serosa or pelvic organs. Incidence: 97, approximately 1 cases of PAS in almost 4,000 pregnancy. 98, approximately 1 in 2,500 pregnancies, starting for 98, 2002, approximately 1 in 500 pregnancies. In 2016, the insights in the United States was reported to approximately in 1 in 270 pregnancies. Risk factors. The strongest risk factors is previous cesarean delivery. On previous cesarean section, approximately 0.3% risk. After a 5 cesarean section, risk is approximately 6.7%. Other risk factors include advanced maternal age, multiparity, previous uterine surgery, history of Asherman syndrome, previous uterine curettage of abortions. Among women with placenta previa and no prior cesarean delivery, placenta-accreted spectrum occurs in approximately 3% of cases. The most likely underlying mechanism is a defect at the endometrial-myometrial interface at the site of placental implantation. Scar tissue lacks normal detitulation, allowing chronicle villi to invade into the deeper layers on the uterine wall. The diagnosis is primarily established by ultrasonography, particularly during the second and third trimester of pregnancy. Placenta-accreted spectrum is frequently asymptomatic until delivery, particularly in the absence of placenta previa. It most commonly presents as prolonged third stage of labor, difficulty removing the placenta during cesarean section, hemorrhage from the placenta implantation site following attempt placenta separation, bulging under the serosal layer. Diagnosed placenta accreta. This patient should be managed by specialists with extensive experience in placenta accreta spectrum. Pregnancy termination may be considered. It may maternal risk justify it. If pregnancy continues, delivery should be planned with full preparation of massive hemorrhage, including an experienced multidisciplinary team, presence of blood production and massive transfusion protocols. Patients should be consulted regarding cesarean hysterectomy as well as uterus preserving alternatives, including their associated risk and possible complications. The timing of delivery should optimize outcomes for both mother and newborn. Current recommendations suggest planned delivery between 34-36 weeks of gestation. Explained management beyond 36 weeks is generally not recommended because nearly half of the women require emergency cesarean delivery before then. If placenta accreta spectrum is diagnosed during vaginal delivery, the umbilical cord should be clamped as close to the placenta as possible. During cesarean delivery, if placental separation is unsuccessful, the umbilical cord is ligated. Blood loss reduction measures are initiated, including tranexamic and administration, vascular suturing, and compression techniques. Hysterectomy is then performed, then indicated. When clinical conditions are favorable and the patient wishes to preserve fertility, several uterus conserving surgical techniques may be considered. In many countries and cultures, hysterectomy may significantly affect a woman's quality of life, physiological well-being, social status, and future reproductive potential. Therefore, whenever staffed possible, conservative surgical management should be considered. On the uterine preserving surgeries is TURIP technique, which is abbreviation for tourniquet uterine inversion removal of placenta. The surgeon elevates the uterus fundus with the assistant manually compressing the cervix and IP ligaments to reduce uterine blood flow. Our 6 French Nelaton catheter tourniquet is placed around the lower uterine segment to maintain hemostasis. After administration of 100 units of nitroglycerin for uterine relaxation, the uterus is manually inverted to expose the placenta implantation site. The placenta is sharply excised, and the tourniquet helps minimize blood loss. The uterus defect is repaired with the layers on intertate vicryl 10 sutures, reinforcing the tint myometrium. Following tourniquet removal and confirm of hemostasis, nitroglycerin is administered again to facilitate uterine repositioning. Barky balloon inflated with 150 milliliter is inserted for intrauterine tamponade, and the uterine incision is closed with 2 interrupted layers without including the serosa. On this slide, you can see them of what I have told. You can save this if you want. So, uterine arterial ligation, floor suture technique. The procedures consist of reflection of the urinary bladder, a high uterine incision for delivery of the newborn without disturbing the placenta, umbilical cord ligation, and intramyometrial oxytocin injection, bilateral uterine artery ligation, gentle manual placenta separation as much as possible. Application on the flower suture technique at the placental implantation site. Resection of the uterine wall is performed only when complete placenta separation is impossible. This is a scheme of a clover suture technique. Compared with cesarean hysterectomy, UAL plus CST as demonstrate lower intraoperative blood loss, reduced need for blood transfusion, lower intensive care unit admission rates of adjacent organ injury and postoperative urinary incontinence are similar between the two approaches. Most patients resume normal menstrual cycle with 1 year with normal menstrual blood loss. This is Barinov technique, which was demonstrated in 2024. A high transverse uterine incision is made 4-5 centimeters above the upper placental edge. The fetus is delivered in umbilically cord in clamped and ligate, and the vaginal balloon is inflated with 118 milliliters of saline. The uterus is exteriorized, and descending uterine arteries are ligated. The placenta bed is assessed. If placenta invasion involves less than 1/3 of the myometrium, the invaded tissue exists. Bleeding vessels are ligated, and the defect is repaired with hemostatic sutures. If invasion exceeds 2/3 of the myometrium is larger than 5 centimeters, the affected uterine wall and placenta are resected, and the uterus is repaired with vicral suture. The vesicouterine space is carefully developed and avoid bladder injury and to expose the extent of placenta invasion. Uterine vessels are ligated above the below in invade area, followed by placenta of hemostatic sutures. The invade uterine wall and placenta are resected. The uterine wall is reconstructed using continuous layered vicral suture, followed by 2-layer horizontal figure-of-8 suture. An intrauterine balloon catheter is inserted before complete uterine closure. The uterine balloon is inflated, the abdomen is closed in layers, and balloon tamponade is maintained before 14 hours. This procedure is again performed and taught only by surgeons who have completed more than 100 cesarean hysterectomies for placenta greater spectrum in specialist referral centers. After entering the abdominal cavity, the placenta invasion site is defined by the characteristic bluish balding appearance. The bladder is dissected downward. Uterine incision is made approximately 1 centimeter above the invasion site. The newborn is delivered and the umbilical cord is ligated. The placenta is removed. A second incision is created beneath the bleeding are to avoid bladder injury. Interrupted horizontal suture are the place to reconstruct the uterine wall. Additional sutures are added as necessary. You can see what I say. Criteria for Jessica. Polar focal accreta invasion less than 50% anterior wall, anterior invasion, no parametrial or bladder invasion. There is some myometrium without placenta implantation at least 3 centimeters above the internal urethral orifice and the cervix. Patient is hemodynamically stable. So, take-home messages. Ultrasonography plays a pivotal role in the diagnosis of placenta accreta spectrum and directly influence pregnancy management. Timing of delivery and surgical planning. Planned cesarean hysterectomy should generally be shielded between 34 and 36 weeks of gestation. Delivery should take place in a specialist referral center where blood transfusion service are readily available and last 3 experienced obstetric surgeons can participate in the operation. Besides hysterectomy, several uterus preserving surgical techniques have demonstrated favorable outcomes and evidence-based effectiveness. Terraform and prenatal diagnosis of placenta accreta spectrum should not automatically be regarded as indication for hysterectomy. And the end, thinking about advanced obstetrical surgery, always remember to recognize your limitations and know when to stop. In the anti-SIPT, surgical outcomes cannot be achieved safely. Better is enemy of good. Thank you for your attention. Thank you, Hasmik, for organization of this Bulging Burgess and webinar. It's very good. Thank you.
Thank you
Thank you so much, Dr. Tigran. We don't have any questions in our box, but one question. How do you decide between conservative management or going to a cesarean hysterectomy?
I prefer conservative management because after conservative management, we can we can give chance for women after reproductive chance. If women have 2 children, and we have many countries who have small demographic situation, and after second cesarean section, when we have a placenta accreta, increta, or percreta, we can give chance. But I say, if we can't stop load, we can stop surgery, conservative surgery, and after this, doing hysterectomy.
Thank you so much, Dr. Tigran. There is one question from Dr. Suraya Awal. She says, very interesting techniques for PSAs, 100 cesarean hysterectomy, what a requisite. To what capacity is the uterine balloon inflated after the uterine reconstruction?
Sorry,
No.
maybe Tigran will be answered on chat because we have limited on time. Please, Dr. Tigran, write your answer to the chat, please. We
Okay.
have limitation for the time.
Thank you.
dear audience, dear speakers. Throughout these 2 days, Professor Louvain, President of FIGO, and Dr. Akanya Neubom, President of WATOG, have been steadfast supports of this initiative and of WATOG's mission of empowered trainees, strengthen international collaboration, and advancing excellence in women's healthcare. And it is great honor to invite Dr. Akanya Neubom, President of WATOG, reflects on the day and the road ahead. Dr. Neubom, the floor is yours.
Good evening, everyone. Can you hear me?
Yeah.
So I want to thank everyone, most especially ASMIC, the WATOG Honorary Treasurer, for putting together this incredible 2 days packed of very insightful presentations. I appreciate the other WATOG officers, the WATOG Executive Board, ENTOG, KOGS, all the presenters, all the speakers, resource persons, everyone who has participated in these webinars. I say a big thank you to everyone, and I hope that we have been able to impact not just knowledge, but potentially practice. So on behalf of WATOG, on behalf of the WATOG executive officers, I say thank you to ASMIC, thank you to IDA of KOGS, ENTOG, all our partners, speakers, and all attendees at this webinar. Thank you very much.
Thank you, dear President. Have you something else, Edith, Leopoldo, or just I finished? So thank you very much, Dr. Ubom, President of WATOG, for your inspiring closing remarks and for your outstanding leadership of WATOG. Over the past 2 days, we have explored the human side of care, prevention of screening, fetal growth, prenatal genetics, placental biology, fetal programming, and the management of complex maternal fetal conditions. More importantly, we have built new international connections that will continue to strengthen education, research, and collaboration long after this webinar concludes. We hope this meeting has inspired new ideas, fostered new partnerships, and reinforced our shared commitment to improving the health of women and babies worldwide. On behalf of WATOG and all our partner organizations, thank you for joining us for building bridges in maternal fetal medicine. We wish you every success in your career and look forward to welcoming you again at future WATOG educational events. Thank you, stay safe, and goodbye. But before goodbye, we need to have photo, group photo
Yes,
with
please.
our speakers, with our professor. So the floor is now regarding us. So, Dr. Ida, can we have a photo?
Yes, absolutely. We could request all the co-chairs and the speakers to put their videos on.
Yes,
And
please
we could
all
also request.
speakers. Yes, today speakers as well. If you are with us, please put in your microphones, put your video screen, and it is privilege for us to have you by our side.
All right, so I'll take one, and then Leopoldo could also take another photo. So in 3, 2, 1. Then Leopoldo, when you're ready, you could also take another picture for us.
Yes, I will take it. 3, 2, 1.
Great.
Done.
Thank you,
Thank you
guys.
so much.